All right. I think that's staying pretty steady now. Maybe we should get started. Thank you, everyone. Welcome. I'd like to begin today by respectfully acknowledging that Lady Eaton College is on the treaty and traditional territory of the Mississauga Anishinaabe. We offer our gratitude to the First Peoples for their care for and teachings about our earth and our relations. May we honor those teachings. You may be elsewhere joining us today, and part of my own practice is to try to, when I travel, is to find out what the territory is that I'm on, and to recognize the importance of acknowledging the land where I am. So I hope you'll do that with us today, wherever you are. I'm so happy to welcome you today to our virtual Lady Eaton College for the first of our speaker series in our new Art and Science of Health and Healing speaker series. Part of the process of Lady Eaton College is coming to sort of look at our strengths and what do we do that's special at Lady Eaton College. And our newest theme is this theme of the art and science of health and healing. It's really about bringing together our interdisciplinary community to be part of a conversation about health and what that means really broadly understood. And I'm so thrilled for our first speaker to partner with the Trent-Fleming Nursing Students Association and to welcome Christy Bucheri. Thanks so much for joining us today. I can't imagine a better topic for us to be discussing. It really pulls together the community that we have here at LEC. We're lucky enough this year to be hosting the nursing, living, and learning community. We're also home to the medical professional stream here at Trent. And we also have a community around leadership and civic engagement. And I think all of those things really pull together in what we're going to talk about today. Our motto at Lady Eaton College is Sapiente e Humanitas, and that is Latin for wisdom and humanity. And really what we try to do is to not just know and understand, but to find out what we can do in our own lives to make the world a better place and how we can use our knowledge and understanding to improve the world in which we live. So thank you all for coming today and for being part of this conversation. And I'd like to turn it over to Julia to introduce our speaker.
Good afternoon, everyone, and thank you for joining us today. I would like to introduce you all to Dr. Christy Buccieri. Christy Boucheri is an associate professor here at Trent in the Department of Sociology. Her research focuses on the health and well-being of individuals experiencing homelessness, and particularly in pandemic times. And she is the co-editor of a book entitled Pandemic Preparedness and Homelessness, Lessons from H1N1 in Canada, and is currently part of a team conducting research on the impact of COVID-19 and homeless serving agencies in rural and remote communities. And today, Dr. Bucheri will be speaking about the COVID-19 pandemic and how it is impacting individuals experiencing homelessness. Evidently, there are a multitude of different factors that have been impacting individuals experiencing homelessness, including limited access to masks and personal protective equipment, stigmatization, and limited access to information on the changing policies of COVID-19, such as social distancing, mask mandates, and isolation procedures. So throughout this pandemic, it has been made very apparent that housing is an extremely important social determinant of health, and that we must work to ensure that everyone has access to adequate housing. So I think I speak for everyone when I say that I'm very thankful to be learning more about this issue and the different ways we can better support individuals experiencing homelessness right now, and how we can be better prepared in the event of another pandemic. So if you have any questions during the talk, please send them in the Q&A section, and we will answer them at the end during our question period. So without further ado, thank you and welcome, Dr. Bucheri.
Thank you so much. Thank you, everyone. Welcome. Thanks for joining us. I'm just going to go ahead and share my screen. so that you can follow along on the PowerPoint. Okay, thank you. So I will be talking today about being homeless in a time when we are told to be home more. We have heard a lot in the news lately about the COVID-19 outbreak and its impact on homelessness shelters, particularly in major urban areas like Toronto. Despite the surprise expressed by many over this outbreak, I will argue that it was inevitable. We currently manage homelessness in a way that makes this population and the environments they commonly inhabit particularly susceptible to pandemic outbreak and to the spread of communicable disease. The issue that I want to address and encourage participants to think about today is this. There is an underlying assumption in public health messaging during pandemic outbreaks, such as COVID-19. We are commonly told to stay home, keep our distance, wash our hands, and get plenty of rest. Yet achieving these goals is only possible if one has the private space in which to do so. Pandemics highlight the existing cracks within our social systems, including the lack of affordable housing. What if, rather than creating separate pandemic plans for people experiencing homelessness, we put our efforts into finding people housing before an outbreak even began? Let's begin by looking at some of the common messages we hear during a pandemic. I'm going to highlight two that are both currently taken verbatim from the Public Health Agency of Canada's website about measures to reduce COVID-19 in your community. The messages are intended for Canadians in general, and when we deconstruct them, when we look closely, we see the ways in which they leave out individuals experiencing homelessness in our communities. Mainstream pandemic planning fails to account for the vulnerable position of individuals experiencing homelessness and for the high-risk nature of the environments where they spend time. The first message or recommendation from the Public Health Agency of Canada website informs Canadians to stay home if you have a higher risk of serious illness. Some people have a higher risk of getting seriously ill. Stay at home as much as possible if you are an older adult, have an underlying medical condition, have a compromised immune system. Talk with your healthcare provider about how to protect yourself. If you have an increased risk of illness and you're working outside the home, consider working from home if possible. Ask your family, a neighbor, or friend to help you with essential errands, like picking up prescriptions and buying groceries. If we look closely at this message and we try to deconstruct it line by line, looking for places where it might not apply to all Canadians, we get stuck on the very first two words, stay home. Use of the word stay implies that a person already has a home in which they can remain. The most recent data from the state of homelessness in Canada, produced by the Canadian Observatory on Homelessness, tells us that 235,000 Canadians experience homelessness each year, and that on any given night, 35,000 people are without housing. These numbers are also likely underrepresentative of the number of people who are truly without housing. Women in particular may be amongst the hidden homeless who are missed in official statistics. So we know that not everyone can stay home because not every Canadian has a home. Returning to the message, we get stuck yet again in the title. Stay home if you have a higher risk of serious illness. This message identifies specific populations of individuals who are older, have an underlying medical condition, and/or a compromised immune system. Canadian research tells us that over the past several years, we have actually seen an increase in the number of older adults and seniors who have become homeless. This subpopulation now accounts for nearly a quarter, 24%, of shelter residents in Canada. Throughout this talk, I will showcase some quotes that are taken from a study that I conducted in the city of Kawartha Lakes with Cindy Gilmer, who is an associate professor in the Trent-Fleming School of Nursing. The study consisted of interviews and surveys with 53 individuals who were experiencing homelessness or were at imminent risk of housing loss. It was conducted prior to the pandemic, before COVID-19 was part of daily life. Incorporating the voices of individuals who have lived experience of homelessness provides an additional layer of insight into the gaps that exist between pandemic advice and the lived reality of its applicability. One older gentleman stated, "I'm not healthy right now. Arthritis in the hips, overweight. There's nothing they can give me. I maintain it with Advil. They keep talking about these drugs that are going to come out, but there's nothing they can do with it, really. It's just part of getting old." The message during COVID-19 that seniors in particular should stay home fails to recognize how many of these individuals have become vulnerable to housing loss, even in non-pandemic times. In addition to seniors, the Public Health Agency of Canada recommends that individuals with underlying medical conditions and/or compromised immune systems should stay home. This graph is taken from the research in the city of Kawartha Lakes and shows the percentage of chronic health conditions reported by 24% or more of the participants. The gray bars relate to physical health conditions like foot problems, fatigue, arthritis, night sweats, asthma, back problems, and dental problems that impact large numbers of individuals experiencing homelessness. The blue bars indicate chronic mental health conditions that were commonly reported, including bipolar disorder, antisocial personality disorder, eating disorder, post-traumatic stress disorder, generalized anxiety, and depression. Homelessness is a social determinant of health. It is very challenging to maintain good health when one does not have housing. Consider this quote from a participant in this study. "My health is bad, but I'm not concerned with it right now. There are other things that are my top priority. When I get them cleaned off my slate, I will focus on my health. I have problems with my legs, my knees, but it's not a priority right now. I prioritize things, and when I get to that, I will look after that. It's not a necessity at this point for me. My knees bother me, big deal. Overall, I'm fine. I have problems with my legs and should go get them checked out, but that's going to lead to doctor's appointments. I don't have time for that." This man was in poor health, but had to prioritize looking for employment, housing, and taking care of his children. For people who experience homelessness, being in poor health often is such an ingrained part of their daily life that it becomes unremarkable to them and subsequently goes untreated. We see this again in this quote from a man who said, "A bad day is stuck in bed paralyzed. I'd say my overall health is poor. Not real poor, but on the low side." For this man, not spending the day in paralyzing pain is the benchmark for a good day. If we think about the COVID-19 messaging to stay home if you have a chronic health condition, we see that not only do many Canadians not have a home, but that these same individuals are amongst the most unhealthy individuals as a whole. Returning to the message, the Public Health Agency of Canada recommends that Canadians talk with their healthcare provider about how to protect themselves. One primary reason that individuals who experience homelessness have poor health is because they tend to be disconnected from healthcare services and providers. A participant in the study told us, "Healthcare has been hard for me. I've been on a wait list for a family doctor for a few years now. The only way I can get medical care is the walk-in clinic or hospital. I have to go to the hospital or a walk-in clinic because it's impossible to find a family doctor. I've been on a waiting list for a year." While it is true that wait lists are a reality for many housed Canadians as well, we see this theme recurring amongst individuals without housing. For instance, interviews with the 53 participants in our study showed that only 15% had a primary care provider, like a physician or nurse practitioner, in the town where they lived. 40% had a primary care provider in another town, often more than 60 kilometers away. It is important here to note that most people experiencing homelessness do not have access to a car. If public transportation is not available between the two towns, then they are closer to the 32% who reported not having a healthcare provider at all. Talking to one's doctor about COVID-19 is good advice for people who have a doctor, but this is not the reality for 3/4 of the homeless population. The message continues by stating that those who have an increased risk of illness should consider working from home when possible. While continuing to assume the individual has a home, this advice also assumes the person is employed. Our research found that only 16% of the people involved were working at the time of the study, and most of those were working part-time positions. The reasons people are without work vary, but often relate to injury or illness, like the participant who stated, "I was building log houses until I broke my back." Unemployment may be related to company restructuring, such as the woman who stated, "I had a good job and then they sold the company, so I lost my job. That was a good job." It is also possible that a person may have lost their employment or be unable to work due to addictions. One participant stated, "I had a business here for years, then got into the opioids, and there went the house and the cars. 6 months down the road, I was living in a trailer." We have seen job precarity associated with the COVID-19 outbreak, but it is important to remember that many people were without jobs before the outbreak as well. Returning again to the Public Health Agency message, we see the advice to ask your family, a neighbor, or friend to help you with essential errands. While stigma is often recognized as being associated with homelessness, there is less awareness of how socially isolating the experience can be. Participants in our study spoke at length about feeling excluded from the general community because of their housing status. For instance, being a small town, everyone has their opinion, no matter what. They're judgmental, different class. I see it with my no teeth. They think you're a bum. If you're dirty, no teeth, they think you must be homeless. Another participant stated, "It's hard. Everybody judges. That's the point of being human. It's like the cover of a book. You don't judge it, but it does have an impact. These quotes were from participants in a small town, but the feeling of being excluded and looked down upon is a common theme across my research in several different cities, small and large. Having friends, neighbors, and community members to provide help is ideal, but it is far less achievable for those who feel like they are on the outside. Finally, this message advises that friends and neighbors may not only be helpful in running errands, but may also be able to help with buying groceries. There is an underlying assumption here, not just that people buy groceries, but that people eat. In another study conducted in Toronto, my team and I interviewed 155 individuals who were experiencing homelessness at the time. It has been well documented that not having housing is a risk factor for nutritional vulnerability. In our study, only 24% of participants had eaten breakfast daily. Only 28% had eaten lunch daily, and 30% had eaten dinner daily. This means that the majority of participants had gone without one or more meals every day. Additionally, and particularly concerning, was that only 44% of participants reported they were able to drink clean water every day. While the message to the general public to get help buying groceries may be valid, it does not reflect the reality of Canadians who live without food or clean water on a daily basis. Another example of pandemic messaging we are hearing during COVID-19 is to keep practicing physical distancing. This message again is taken from the same Public Health Agency of Canada site, designed to provide the general Canadian public with advice during the outbreak. While the first message highlighted the vulnerability of individuals who are experiencing homelessness, this message shows us the risks that are present in their social and physical environments. It reads, keep practicing physical distancing. Keep practicing physical distancing as your local governments lifts public health measures. Physical distancing minimizes close contact with others in your community. Things you can do to keep practicing physical distancing are avoiding crowded places, reducing non-essential travel and trips out of your home, keeping 2 meters away from others when outside of your home, commuting outside of the busiest hours if you use public transit, avoiding greetings that include physical contact, such as handshakes, following your local public health guidance on the number of people that can gather in one place at one time. If we break this message down to see how well it addresses the unique needs of individuals experiencing homelessness, we again get stopped in the title. Keep practicing physical distancing implies that this is a reality people are able to engage in. Included in this advice is to avoid crowded places, limit the number of people gathered, and keep 2 meters away from others. Canada relies heavily on institutional management of homelessness today. This includes shelters, hospitals, group homes, and correctional facilities. Physical distancing is not a particularly useful strategy or message for people who rely on service agencies like shelters and food banks in order to meet their survival needs. We know from previous research conducted during H1N1 that even in a pandemic, people who rely on service agencies are likely to continue using them. These settings are crowded and often at full capacity. Shelter space is often cramped, And much of this has to do with the initial building designs. Shelters that have been adapted from other buildings, particularly from those that used to be warehouses, may struggle with creating private spaces for residents. This is often apparent in the sleeping arrangements. Although some shelters offer private rooms, the majority of homeless residents share sleeping quarters with others. My own research indicates that the majority of individuals, 61%, have 1 to 5 other people in the room with them at night. 32% have 6 or more, even up to 100 people. And only 7% had a room to themselves. How does a person keep their distance in a room with 99 other people? In these circumstances, the only way to follow public health advice to avoid crowded places is to avoid going to a shelter altogether. But that begs the question, where then do you sleep? Tents are one solution, but they are quickly taken down by the municipal bylaw or sworn peace officers. Avoiding people at drop-in centers like soup kitchens and food banks is equally challenging. The Public Health Agency of Canada recommends keeping 2 meters away from others when outside your home. This infographic represents findings from the same study in Toronto. Participants were asked to think about the last time they were at an agency. Again, this was before the pandemic. And to identify how many people were within 2 feet of them at any given time. 2 feet was chosen because it is slightly less than the average human arm. Take a moment, your cameras are off. Hold your arms out in front of you. How many people can you currently touch? In this study, only 12.8% of people said that they could touch no one. Nearly 42% could touch 5 or more people just by standing in place and reaching out their hands around them. Consider that this is 2 feet. The Public Health Agency recommendation states there should be no one within 2 meters. Avoiding crowded places when you are experiencing homelessness means going without shelter and without food, which, as we have already seen, is already not guaranteed. Finally, this second message advises people to reduce non-essential travel and trips out of their home. This is a time geography map that shows how a young man who was homeless spent a 24-hour period in Toronto. Along the bottom is the map. Along the vertical axis is the time, using a 24-hour clock with 1-hour intervals. The red stars represent the places where he stopped and spent time. The yellow lines represent the routes he traveled, and the colored bars show how long he was in each location. Looking at this young man's day, we can see that he spent most of his time at a shelter, various social service agencies, and public parks. The reason for this is that each organization would open and close at different times of the day. He, like many other people who experience homelessness, had to travel between agencies throughout the day in order to have shelter, food, and social contact with others. It is nearly impossible not to move through a city when your daily needs rely on accessing a number of service agencies that are scattered throughout it. Consider this map that combines the routes of 10 individuals experiencing homelessness in Toronto. Each color line represents a different person. We see considerable overlap in the downtown core, where the agencies are primarily located, and some travel out to shelters or temporary places to sleep in the outlying areas. Staying away from others and in one location is only possible if your needs for food and shelter can be met where you are. Clearly, mainstream public health messages, such as those provided by the Public Health Agency of Canada for the general public, do not adequately address the vulnerability of individuals experiencing homelessness or the high-risk environments in which they find themselves. To address this, we see specialized planning for homelessness within the context of pandemics. Here's the Government of Canada's site that provides guidance for providers of services for people experiencing homelessness. And while these tips and pieces of advice may be more relevant, it again begs a larger question. Why do we create specialized plans for people experiencing homelessness rather than focusing on the issues that make them vulnerable to pandemics in the first place? Would it not be simpler to house people so the mainstream planning would apply to them? Thomas Appleyard tells us, emergencies are no longer understood as rare, unpredictable events where chaos reigns. Emergencies are quite common, and the way in which emergencies play out is rooted in social patterns established during non-emergency times. We know that people who are vulnerable before a pandemic are going to be even more vulnerable during it. As we know with COVID-19, pandemics make life harder, not easier. If a person is already facing difficulties, there's a high likelihood that will continue and become worse during an outbreak. But there is good news. The predictable nature of pandemics and the pre-existing difficulties associated with homelessness point us to clear solutions. One of the most common messages we have heard during COVID-19 is to stay home. By focusing on getting people housed, we address many of the additional vulnerabilities that homelessness creates. Housing in itself is not a sufficient solution. The housing must be affordable, of an appropriate size, and in a location that is desirable to the resident. We can think about the principles of housing first as a guide here. Housing first is a recovery-oriented approach to ending homelessness that centers on quickly moving people experiencing homelessness into independent and permanent housing, and then providing additional supports and services as needed. Housing First has 5 core principles. The first is the immediate access to permanent housing with no housing readiness requirements. Housing First is exactly what it sounds like. The person is connected with housing without needing to meet specific criteria beforehand, like demonstrating sobriety or having a steady income. The second principle is consumer choice and self-determination. All individuals require a sense of community and connectedness to others. We have seen already that homelessness is a socially isolating experience. Housing First means that people get a say in where their housing is located. Perhaps that means in a particular neighborhood where they have family or friends. The third principle is that of being recovery-oriented. Housing First emerged as a way of supporting individuals with complex needs, such as comorbid addictions and severe mental illness. This approach is about nurturing people and improving lives, not simply meeting their basic need for shelter. The fourth principle, individualized and client-driven supports, means that services are tailored to what a person needs and wants in a way that is meaningful to them. This may mean a focus on being culturally appropriate, recognizing gender, sex, and sexuality specific needs, and taking into account that what one person needs for their well-being might be different than what another person needs. Finally, the fifth principle of Housing First is that of social and community integration. The focus is on helping people to become stably housed over time, such that supports are not as needed as the client becomes more integrated into the community around them. If we can get all of that right, if we can find people suitable housing that has supports built in, we can give them a private space to stay. We can improve their health and reduce many of the chronic conditions like foot and back pain that come from walking around all day. We can provide people with a permanent address so that they can register for healthcare providers and have reliable contact information. They can look for work rather than focusing on finding housing. They can become more socially included in their local community. And they can connect with service providers and organizations to assist with nutritional supports. Having a home means being able to stay and shelter in place, to close a door and feel the safety and security of not having to move along, of being able to rest. There are 4 key takeaway messages here. First, vulnerabilities that exist before a pandemic will carry into a pandemic. Homelessness is a large vulnerability that impacts many aspects of a person's life. This includes their health, access to health care, employment opportunities, social inclusion, access to food and water, ability to get their daily needs met, and access to private space that is separate from other people. Mainstream pandemic planning, as we have seen in just 2 examples, does not adequately meet the needs of people experiencing homelessness. Rather than changing the plans, as we currently do, we should instead focus our attention on addressing the underlying vulnerabilities. Getting people securely housed is one of the best public health investments we can make for individuals and for our society as a whole. If you would like to learn more about this topic and the research presented throughout, please check out these freely available sources. Thank you.
Okay, so I guess we will move on into our question period. Thank you, Dr. Bucheri, for that. So if you have any questions, please feel free to put them in the Q&A chat, and then I will read them aloud for Dr. Bucheri to answer. I guess I can start off with a question of myself. So what are some strategies that you believe may be useful in harm reduction and health promotion during this pandemic for the homelessness?
Excellent question. So harm reduction is an approach that looks at so harm reduction is an approach that really looks at individuals and how do we make sure that they are leading the best lives possible in a way that is open and non-judgmental and respectful. So we may think of harm reduction particularly around addictions and or mental illness. And so around addictions, we see things like safe injection sites, we see things like distributing clean works kits. And so particularly during a pandemic, it's really important to make sure that we are reaching the most vulnerable individuals, and certainly individuals who are struggling with addictions, and potentially severe mental illness are going to be amongst the highest risk individuals. Harm reduction is an important way of reaching out to people and saying, we're going to make sure that you get what you need, we're going to help you, and we're going to do that in a way that is not judgmental, in a way that is respectful. So Housing First is very much based on the principles of harm reduction, that we say you don't have to meet a certain number of criteria. You don't have to prove that you are abstaining from substance use. We're going to focus on getting you housed, and we're going to do that first. And then once you're housed, we will look at all of the other issues that you may want to work on. And a lot of that, the important piece of that is the consumer choice. So the individual has to say themselves, this is something that I want to address. And so it's not forcing people into anything, it's really listening to people and saying, what do you need to be well? And I think that during COVID-19 in particular, we've seen this sort of public discourse about wellness. And that goes around homelessness, but also for people who are housed, really just part of a bigger discussion of how do we be kind to ourselves? How do we make sure that people are being taken care of? And how do we do that in a way that addresses what that person needs? So extending that out into individuals experiencing homelessness, certainly taking a harm reduction approach and thinking about, let's get people housed first is a great place to start.
Great, that's great. So we have a question in the Q&A. Could you speak on COVID-19's impact of closing/delaying essential services for those experiencing homelessness?
Sorry, could you just repeat that?
Sorry.
It went out just slightly.
Sorry, could you speak on COVID-19's impact of closing and delaying essential services for those experiencing homelessness?
Right, okay. So services and service use is particularly challenging around a pandemic. So some of my previous research was around H1N1, and we looked at this issue of service usage. And what we found was that most people who use services like a shelter or like a drop-in center do continue to use them during an outbreak. And they do that because they need to, right? Because there's not an alternative. If you rely on an organization for shelter, if you rely on them for food, if that's where your community is, where you know people and where they know you, you're going to be inclined to still go there. But at the same time, these organizations are not designed primarily to be healthcare serving organizations. And so to expect that they'll instantly be able to adapt to a pandemic plan is perhaps a lot to put on these organizations. They already are dealing with the emergency and the crisis of homelessness. So to say, you're going to be managing this crisis of homelessness and now also managing a crisis of a pandemic is an awful lot to take on. So often organizations will sort of be forced to close or forced to alter their hours in a way that makes sense for the organization. But it is challenging for the clients because they do still require the services, they do still seek them out. And we've found that they will continue to do that in a pandemic. Part of our H1N1 research, we did ask participants, if there was a worse pandemic down the road, would you still continue to use services? And the majority of them said, yes, absolutely. Shelters less than drop-in centers, but the majority did say, we would still continue to go to shelters. We would still continue to go to drop-in programs because that's where you get your food and that's where you stay and that's where you have some shelter from the elements. So it's a tricky thing because you need to balance the needs of the organization and what they are funded and staffed to do with the needs of the client. And there's really no one size fits all model of that. Each organization, I think, really needs to look at their own planning, their own budget and think about how can they adapt and do that in real time. And then also from a funder's perspective, they need to recognize that perhaps while you fund a position or a program at a time like this during a pandemic, maybe that position can be leveraged in a different way. Maybe it's not as essential that we run this program, but maybe we can take that person and expand what they do and make them more of a COVID focused response. So it's certainly a challenging topic. It's one that people are struggling with. If there are service providers who are interested, I do know within many of the national organizations, there are these discussions going on, whether it's the National Canadian Alliance to End Homelessness or the National Canadian Observatory on Homelessness. There are organizations across Canada who are all trying to navigate these same issues and having these discussions. So I would certainly encourage people to join those conversations and learn some best practices from what others are doing. And it may be something that's, you know, totally creative and unique, and a lot of the best strategies come out of the communities and come out of the grassroots level. So reach out and find out what others are doing.
Yeah, I know currently, like in my nursing classes, like we're learning more about how to tailor interventions and stuff like that more to a community level, and how that's so much more effective to look at like the intersectionality of any issue in general. So it's
Yeah,
great.
absolutely. The communities are amazing.
Yeah. And so what are some more upstream approaches to addressing homelessness during the pandemic? Housing first sounds great, but in the GTA and Toronto especially, there's such a housing shortage that the wait list is years long.
Right, they're absolutely right. And housing first, I always say, is wonderful and it's a great ideal, but we need the housing to put people into. And currently this is a gap. It's something that we're struggling with across Canada and certainly locally as well. The government of Canada has put in a substantial amount into the homelessness plan around the homelessness strategy around COVID-19. But again, that largely focuses on designated communities. So if you are not a designated community, you may be less available to get those funds to help with housing, to help building that in your community. So upstream, again, I would say really it's about thinking about what your community needs and what your community can do at a local level. There are many really great programs thinking about housing sharing and thinking about housing in a different way. So for instance, how do we perhaps find communities, and Peterborough is certainly one, where there is a really rough rental market, where there's not many units available for rent, and those that are tend to go very quickly. So perhaps in communities like this where we're struggling and where housing might not be available in the immediate future, how do we think more creatively about it? And maybe that's finding seniors who have a room to rent in their home, and a student who would like to live in a shared arrangement. So we don't necessarily need to think about it as being every person needs their own individual standalone housing as a single detached home, but how do we put people into a place that feels like theirs? And that generally, again, means going back to a person and saying, what is it that you need? And when in my own research, when I talk to people who are experiencing homelessness about what it is they want, the responses tend to be very practical. So it isn't, you know, I want a mansion in the woods with, you know, armed guards around me. It's, I want a room and I want a space where I can cook. I want a space where I can invite a friend over and they can spend the night if they need to. So if we start thinking about housing as really giving people a private space that feels like theirs, then we can open up what might become available. And so looking at programs where people might be sharing or they might be living in some sort of joint arrangement, we find that in fact, it greatly increases the number of housing that is actually available in our community. So thinking about it differently and thinking about how do we perhaps share housing is a really great strategy that some communities have adopted, and I think works particularly well in communities where there is very limited rental housing available.
That's great. And how would you propose overhauling the community housing program in Ontario for a start in order to allow older adults with lower socioeconomic status to apply easily and to age well in place?
Mhm. Right.
Mhm.
So aging well in place is certainly a governmental priority, and it's one that we've seen increasing over the years, where there have been more tax breaks and tax incentives to help people adapt the housing that they're in. Now, certainly there are benefits to that, and people get to keep their housing, or they get to find new ways to live in the housing that they're in. But it also means that our housing market doesn't change as people are staying in place. There's less options for other people to come into the community. So how do we rethink our social housing is challenging because it is done differently in different communities. It's funded through different levels of government and different programs, and it is constantly changing. And so I think one of the things we need to do is really wrap our head around what is that policy and how does one section of the government speak to another. We've seen this during COVID. The gaps in our system have become very apparent. And I think that that's one thing that we need to pay attention to, is recognizing how the gaps were perhaps predictable in many areas. And affordable housing, social housing programs are certainly one of those. We've seen that in the long-term care homes, and the challenges and the levels of death that have occurred within that system as well. So I think that now is the time to look at our systems and see what is working and what is not, but that's really going to be an across the board conversation. We need to talk to people who are living in social housing, who are looking for affordable housing. We need to talk to landlords. We need to talk to community members across the board and figure out, how do we set this system up in a way that makes sense for people and is accessible and is perhaps more unified, so that people who are entering understand all of the forms and the processes and the policies that go into that. So it's not, unfortunately, it's not a straightforward answer, but it is a very challenging question. So I appreciate that. And I think we need to think about that on a larger scale across the community, across the province, across the country, and even look to what other countries are doing as well.
Mhm. I think we have time for one last question. So one participant has said that they have just joined the board of directors for the Backdoor mission in Oshawa. So the Backdoor mission is part of Mission United, which acts as a hub for our clients' hot meals, harm reduction supplies, healthcare, Ontario Works, clothing, emergency food pantry, etc. So from a board of governance standpoint, is there best practices that we could introduce, and are there resources that you could point me to?
Yeah, so board of directors certainly is a very important job in helping shape the direction that an organization takes and the priorities that they have. The number one thing that I would say across all organizations and boards is kindness is particularly important. And kindness in the sense of what people are doing is pretty remarkable during a pandemic. And so what they're perhaps mandated or funded to do may look very different than what they actually are doing. And that's okay. And I think that that's an important message. So as reports come in and somebody says, well, this is what my position is and what I was funded for, but I didn't do as much of that right now because I'm actually managing this crisis, or I'm actually on outreach, or I'm, getting personal supplies together for our clients, that's okay at this time. So perhaps we need to focus less on these targets and whether we're checking every standard box, and think more about, are we doing good for our community and for the clients who come to organizations for support. And that was a really big message that came out of our H1N1 study in particular, was that people felt really restricted, and people within organizations felt really restricted by what they were funded to do, what the description of their roles were. And so they wanted to be able to work towards helping people in a pandemic, but it wasn't necessarily in their job description. And so I think at this point, really from a board perspective, we need to just really understand that people are trying to help their clients. They have their clients' best interests. And so if that looks slightly different than it was proposed on paper, maybe that's okay right now. So kindness and flexibility are the best things that you can offer. And again, I would direct you probably to the Homeless Hub website, homelesshub.ca, and it does have a number of resources for service providers. And I'll do a little plug as well for our H1N1 lessons in Canada. It's a free ebook, and it does have information that's a bit of a toolkit for organizations working through pandemics with populations experiencing homelessness.
That's great. Yeah, I think it's really interesting that you kind of talk to the best thing that we can do is act with kindness. And even if it's not kind of in our scope or kind of like in our job description. I know earlier this semester, I read an article about a physician who actually gave one of their patients or clients a tent because they're experiencing homelessness. And that was how that they would be benefited most. And I think it's just very interesting and a very good message to take. So I think that's all the time we have for questions. So thank you everyone for coming out today and being so engaged. And thank you again, Dr. Bucheri, for taking the time to talk with us today. I know it was very interesting.
Thank you everyone for joining us. And gosh, I have to admit I was welling up a little bit. It's been an emotional weekend for all sorts of reasons, but to end this with kindness and flexibility, I think is an excellent takeaway message. Thank you so much. I want to let everyone know that we were recording this and we will be posting it on our Lady Eaton YouTube, and it will take us a little bit to work out make sure we have it all closed captioned. So we will send out an email to everyone who registered today so that you have access. And so you know where to find the link for this video if you'd like to go back and see any other resources. Thank you so much everyone today for joining us, and have a wonderful day.
Bye. Thank you.